Hi, class, and welcome to our next lecture on models of abnormal psychology. Today, we will continue our discussion of the three models of abnormal behavior. We had previously discussed biological perspectives and psychological perspectives, ranging from the behavioral perspective to the psychoanalytic perspective to the cognitive behavioral perspective and humanistic existential perspective, but no discussion would be complete without also addressing the sociocultural perspective. So while this discussion will be brief and will certainly not be exhaustive, for the purposes of this course, it is really important to understand that there are socio-cultural factors that are present in affecting the overall effectiveness of treatment and accessibility of treatment to varied populations, as well as the ways in which different populations perceive of treatment, which can present as either a positive to gaining treatment, an attractor to treatment, or a detractor from treatment. Let's get started. So, outside of biological and psychological factors on mental illness, race, ethnicity, gender, religious orientation, socioeconomic status, sexual orientation, etc., also play a role. And this is the basis of the sociocultural model. How so? Well, we'll explore a few of these factors in this lecture. Um, Gender factors play an important, though at times unclear, role in mental illness. Gender is not a cause of mental illness, though differing demands placed on males and females and non binary individuals by society and their culture can influence the development and course of a presentation of a disorder. Consider the following: rates of eating disorders are higher among women than men. Though both genders are affected, men and women, and also non binary individuals are affected, in the case of men, muscle dysphoria is of concern and is characterized by extreme concern over being more muscular. OCD has an earlier rate of onset when comparing females to males, with most people being diagnosed at 18 or 19 years old, I should say. Females are at a higher risk of developing anxiety than men, and ADHD is more common in males than females, though males are more likely to have inattention issues. Trans individuals are more likely to have suicidal ideation than some other groups, and boys are more likely to be diagnosed with autism spectrum disorder than females. Depression occurs with greater frequency in females than males, and women are more likely to develop PTSD in comparison to men. Rates of seasonal affective disorder are 4 times greater in women than men. Interestingly, younger adults are more likely to develop seasonal affective disorder than older adults. Consider this: in relation to men, quote, while mental illnesses affect both men and women and trans individuals, the prevalence of mental illness in men is often lower than women. Men with mental illness are also less likely to have received mental health treatment than women in the past year. However, men are more likely to die by suicide than women, according to the Center for Disease Control and Prevention. Recognizing signs that you or someone that you love may have a mental disorder is the first step towards getting treatment, and the earlier the treatment begins, the more effective it can be. In relation to women, quote, some disorders are more common in women, such as depression and anxiety, and there are certain types of disorders that are unique to women. For example, some women may experience symptoms of mental disorders at times of hormone change, such as perinatal depression, premenstrual dysphoric disorder, and perimenopause-related depression. And when it comes to other mental disorders such as schizophrenia and bipolar disorder, research has not found differences in the rates at which men and women experience these illnesses, but women may experience these illnesses differently. Certainly, symptoms may be more common in women than in men, and the course of illnesses can be affected by the biological sex of the individual and gender presentation of the individual, as well as they relate to their society of origin. Researchers are only now beginning to tease apart the various biological and psychosocial factors that may impact mental health of both women, men, and trans identified individuals. And unfortunately, the body of research disproportionately leans towards binary presentations of gender and sexuality. And so that's an important one to consider as well when we talk about this research, that there's still a lot more to be done, although research on non-binary individuals is underway in the psychological research community. Um, Now, environmental factors are also play a role in the development of mental illness. How so? Well, in the case of borderline personality disorder, which we'll be touching on later in the course, many people report experiencing traumatic life events such as abandonment, abuse, unstable relationships, or hostility and adversity during childhood. Cigarette smoking, alcohol use, and drug use during pregnancy are risk factors in ADHD. Divorce or death of a spouse can lead to anxiety disorders. Trauma, stress, or other extreme stressors are predictive of depression. And malnutrition before birth, exposure to viruses, and other psychosocial factors are potential causes of schizophrenia. Seasonal affective disorder occurs with greater frequency for those living in the far north or south of the equator. And Horowitz, in their 2008 study, found that rates of seasonal affective disorder are just 1% for those living in Florida and 9% for Alaskans who are diagnosed with the disorder. So context and environment plays a huge role. Multicultural factors such as racial, ethnic, and cultural elements are also relevant to understanding the development and course of mental illness. Multicultural psychologists assert that both quote unquote normal behavior and quote unquote abnormal behavior needs to be understood in the context of the individual's unique culture and the group's value system from which they come. Racial and ethnic minorities must contend with prejudice, discrimination, racism, nationalism, economic hardships, ethnocentrism, etc., as part of their daily life. And this can lead to disordered behavior, thinking, and feeling. Though some research suggests that ethnic identity can also buffer against these stressors and protect mental health. To address this unique factor, culturally sensitive therapies have been developed and include increasing the therapist's awareness of cultural values, hardships, stressors, and or prejudices faced by the client, as well as their own ethnocentrism and inherent biases, and the identification of suppressed anger, pain in the client, raising the client's both personal awareness and self-worth. These therapies have proven efficacy for the treatment of depression and schizophrenia, among others. But let's look at a sociocultural perspective hypothetical case study. So the sociocultural perspective looks at you, your behaviors, and your symptoms in the context of your culture and background. So, for example, Jose is an 18-year-old Hispanic male from a traditional family. Jose comes to treatment because of depression. During the intake session, he reveals that he is gay and he's nervous about telling his family. He discloses that he is concerned because his religious background has taught him that homosexuality is wrong. How does his religious and cultural background affect him? How might his cultural background affect how his family reacts if Jose were to tell them that he is gay? As our society becomes increasingly multi-ethnic, multiracial, and multinational, mental health professionals must develop cultural competence, which means that they must understand and address issues of race, culture, and ethnicity. They must also develop strategies to effectively address the needs of various populations for which Eurocentric therapies have a limited application. For example, a counselor whose treatment focuses on individual decision making may be ineffective at helping a Chinese client with a collectivist approach to problem solving, meaning that they focus on the well being of the group versus the individual. Multicultural counseling and therapy aims to offer both a helping role and a process that uses modalities and defines goals consistent with the life experiences and cultural values of a client. It strives to recognize client identities, to include individual, group, and universal dimensions, to advocate the use of universal and culture specific strategies and roles in the healing process, and balance the importance of individualism and collectivism in the assessment, diagnosis, and treatment of the client and client's systems. This therapeutic perspective integrates the impact of culture and social norms starting at the beginning of treatment. Therapists who use this perspective work with clients to obtain and integrate information about their cultural patterns into a unique treatment approach based on the particular situation. Sociocultural therapy can include individual, family, and couples treatment modalities. How do your cultural and religious beliefs affect your attitude towards mental health treatment? Well, this is an important perspective to look at, right? We want to understand the impact of one's own framework to how they approach psychotherapy. So statistically, ethnic minorities tend to utilize mental health services less frequently than white identified middle class Americans. Why is this so? Well, perhaps the reason has to do with access and availability of mental health services. Ethnic minorities and individuals of low socioeconomic status as well report that barriers to services include a lack of insurance, transportation, and time. However, researchers have found that even when income levels and insurance variables are taken into account, ethnic minorities are far less likely to seek out and utilize mental health services. And when access to mental health services is compared across ethnic and racial groups, differences in service utilization remain. In a study involving thousands of women, it was found that the prevalence rate of anorexia was similar across different races, but that bulimia nervosa was more prevalent among Hispanic and African American women when compared to non-Hispanic whites. Although they have similar or higher rates of eating disorders, Hispanic and African American women with these disorders tend to seek and engage in treatment far less than their Caucasian counterparts. These findings suggest ethnic disparities in access to care, as well as clinical and referral practices that may bias against or prevent Hispanic and African American women from receiving care, which could include a lack of bilingual treatment, stigma, fear of not being understood, family privacy, a lack of education about eating disorders, or what some studies have shown, which is a lack of perception of or appreciation of pain among people who are darker skin tones in comparison to people who are lighter skin tones when perceived by treatment providers, regardless of their own ethnic background or racial background, which says something about bias within the kind of larger culture, the monoculture, and how that distills down to treatment providers at times. And this isn't just psychologists, I should add, or therapists, I should add. This is also among physicians and other medical treatment providers as well. Perceptions and attitudes towards mental health services may also contribute to this imbalance. So, a relatively recent study at King's College London found that many complex reasons exist for why people don't seek treatment. Self-sufficiency and not seeing the need for help, not seeing therapy as effective, or concerns about confidentiality, and the many effects of stigma and shame are all contributing factors. And in another study, African Americans exhibiting depression were less willing to seek treatment due to fear of possible psychiatric hospitalization, as well as fear of treatment itself. And instead of mental health treatment, many African Americans prefer to be self-reliant or use spiritual practices such as seeking support through their church or place of worship. And that's important because it's been found that the Black church plays a significant role as an alternative to mental health services by providing prevention and treatment type programs designed to enhance the psychological and physical well-being of its members. And it makes sense considering this country's history of grossly unethical treatment practices in both the offering of treatment and research when it comes to medicine in this country. I would encourage all of you to look up videos on the Tuskegee syphilis study if you were not previously aware of it. Or didn't view it in your introductory psychology course. Really horrible stuff that has been done to that population in this country. The other piece that is worth noting is also that there is some research to suggest that there is a disproportionate perception among mental health treatment providers of severe mental illness among African Americans when none may exist, or it may not be a different presentation or severity when compared to lighter skin counterparts. So it really does suggest some issues of either systemic bias or alternatively, that one's own individual racism or bias is coming through in treatment. And we're seeing this on a grand scale. So, all the more reason why it is so important for treatment providers, going all the way back to when they are students, be educated on really dispelling themselves of their own biases and becoming aware of them so it doesn't filter down to having a negative effect on those who are seeking treatment. But still, there is increasing rates of mental health service utilization among African American communities and among persons of color. And additionally, there are growing numbers of treatment providers who themselves are persons of color, which can help to work against some of the biases within treatment and access to treatment as well. But going back to some of the other issues, additionally, people belonging to ethnic groups that already report concerns about prejudice and discrimination are less likely to receive and seek services for mental illness because they view it as an additional stigma. For example, one somewhat recent study of 462 older Korean Americans over the age of 60, a significant portion of participants reported suffering from depressive symptoms. However, 71% indicated that they thought the depression was a sign of personal weakness, and 14% reported that having a mentally ill family member would bring shame to their families. So there's the perception, which is a barrier to treatment, where especially among Asian populations, you may see them presenting first with physiological complaints to their primary care physicians before they get referred to a therapist's office, because they'll look at the kind of psychosomatic presentation rather than the psychological layer disproportionately because of cultural value systems against seeking mental health treatment or having mental illness. Language differences are a further barrier to treatment. In a previous study on Korean Americans' attitudes towards mental health services, it was found that there were no Korean-speaking mental health professionals where the study was conducted. And because of the growing number of people from ethnically diverse backgrounds, there is a need for therapists and psychologists to develop knowledge and skills to become culturally competent. And those providing therapy must approach the processes from the context of the unique culture of each client. So the last point on this is to look at prevalence rates and the significant impact to barriers to treatment and treatment perceptions. By the time a child is a senior in high school, 20% of their classmates, that's 1 in 5, will have experienced mental health problems. And 8%, about 1 in 12, will have attempted suicide. This is according to the CDC, Center for Disease Control and Prevention, in 2014. Of those classmates experiencing mental health disorders, only 20% will receive professional help. Why? Well, it seems that the public has a negative perception of children and teens with mental health disorders. According to researchers from Indiana University and the University of Virginia and Columbia University, interviews with over 1,300 U.S. adults showed that they believe that children with depression are prone to violence. and that if a child receives treatment for a psychological disorder, then the child is more likely to be rejected by their peers at school. Uh, Bernice Pescadillo, author of the study, asserts that this is a misconception. However, the stigmatization of psychological disorders is one of the main reasons why young people do not get the help they need when they are having difficulties. The researcher and her colleagues caution that the stigma surrounding mental illness is based on misconceptions rather than facts and can be devastating to the emotional and social well-being of our nation's children. This warning played out as a national tragedy in the 2012 shootings at Sandy Hook Elementary. And in her blog, Susie DeYoung in 2013, co-founder, I should say, of Sandy Hook Promise, the organization parents and concerned others set up in the wake of the school massacre, speak to treatment perceptions and what happens when children do not receive treatment, the mental health treatment, I should say, that they desperately need. So we can see that there are some key takeaways here around the importance of a sociocultural and destigmatizing approach. So, what are the key takeaways? Well, the sociocultural perspective looks at you, your behaviors, and your symptoms in the context of your culture and background. Clinicians using this approach integrate culture and religious beliefs into the therapeutic process. It is not a therapeutic process in and of itself, but it is a lens with which all therapeutic processes can be viewed. Research has shown that ethnic minorities are less likely to access mental health services than their white middle class American counterparts. And barriers to treatment include lack of insurance, transportation, time, cultural views that the mental illness is a stigma, fears about treatment, language barriers, and biases within the healthcare field. The sociocultural model has contributed, I should say, significantly to our understanding of the nuances of mental illness diagnosis, prognosis, course, and treatment for other races, cultures, genders, and ethnicities other than the kind of Eurocentric norm. So we're going to talk about, as we move on in the course, diagnosing and classifying abnormal behavior from the perspective of the DSM-5-TR. But important here is that specific culture and gender related diagnostic issues are discussed for each disorder, demonstrating an increased awareness of the impact of these factors. And it's also worth mentioning that this will be incomplete because the research is incomplete and because this is a undergraduate psychology course. Still, the sociocultural model suffers from unclear findings, not allowing for the establishment of causal relationships, and a reliance on more qualitative data gathered from case studies and ethnographic analyses, and an inability to make predictions about abnormal behavior for individuals from various cultural backgrounds. Still, it is important that we avail ourselves of all the information that we possibly can and a lens of the importance of culture, socioeconomics, race, sex, and gender as they interact with mental health concerns and perceptions of it. More to discuss. Take good care, guys. I look forward to reading your discussion posts.